I'm going to go back to basics and talk about arterial conduits in general. The majority of patients that come to cardiac surgeons have 2 or 3 vessel disease, and therefore they need 2 or 3 grafts. However, and the standard operation in many parts of the world and in the UK is a LIMA to the LAD and a vein graft to the OM and the PDA. And as we have heard before, about only 20 to 25% of patients have 2 or more arterial grafts, and only about 10 to 15% of the patients have bilateral internal mammary artery grafts. Now, what is an ideal conduit? An ideal conduit is one that's simple to harvest. It should be available in large supply. It should not produce complications at the site of harvesting, should cause minimal tissue reaction when it's put on the heart, and should be easy to handle. And of course, it should have excellent short-term and long-term patency. And I'll put to you that there is no ideal conduit available. Every conduit has advantages and disadvantages. And if you look at a vein graft, it will tick the first 5 boxes very easily. And why are arterial grafts better? We've heard a lot in the previous talks. One of the advantages of an arterial graft is that it has a protective effect by reducing the progression of native coronary artery disease in the grafted vessel. And arterial grafts are durable as well. And we've heard just now that the internal mammary artery graft, at 1 year, the patency rate is about 95%, and at 10 years, it's in the region of 90%. And in saphenous veins, angiographically, at 1 year, the patency rate is about 85%, and at 10 years is less than 50%. And why are arterial grafts better? Technical factors may play a role in why saphenous vein grafts don't do well. Harvesting techniques or using high intraluminal pressure to dilate the vein to look for holes or side branches may play a role. Now, atherosclerosis is a generalized disease, and it affects all the arteries in the body, but the internal mammary artery is one artery that is relatively resistant to atherosclerosis. And now, one unique feature of the endothelium of the internal mammary artery is that in response to injury, the intima constantly remodels itself, and that process, that phenomenon is called sequiescence, and that provides a degree of protection to the internal mammary artery. The endothelial cells of the internal mammary artery are very close together. The intercellular junctions are very tight, and therefore they are less permeable to transport of lipoproteins from the lumen into the wall. And as we know, that is the first step in the formation of atherosclerotic plaques. And this is one of the reasons why internal mammary artery, the incidence of atherosclerosis is very low. The endothelial cells of the internal mammary artery have a very high concentration of heparin sulfate and endothelial nitric oxide synthase. So they synthesize a lot of nitric oxide, and that has antithrombotic properties, and they maintain endothelial homeostasis and therefore prevent atherosclerosis. Now, we've seen histologically arterial conduits are better. Angiographically, they have better results. Do they result in a survival benefit? And again, I'll just repeat this same study that John quoted earlier. Bruce Lytle looked at 10,000 patients operated between 1971 and 1989, and you can see the figures yourself. At 10 years and 20 years, there was a significant survival difference. Another study that I would like to quote is one from Florida. Kurlansky looked at 4,500 patients, and the reason I've chosen this study is because of the length of follow-up. The patients were followed up for 32 years, some of them. And also the proportion of patients receiving bilateral internal mammary arteries was about 50%. Now, in this study, the 25-year survival was 16% versus 25%, a significant difference. So there's a lot of data from observational studies that there is a survival benefit with bilateral internal mammary arteries. And does the location matter? Whether you put the right internal mammary artery on the right-sided circulation or on the left-sided circulation, survival is similar, and there are lots of studies. Kurlansky's study is one of that. They looked at the right internal 2/3 of their patient had the right internal mammary artery going to the left system, and 1/3 of them went to the right system, and survival was similar. I won't go into the configurations. There are a number of ways in which you can use the mammary arteries. 2 of the common configurations are mentioned here. Let's skip this. And now we know there is a survival benefit, and however, it's only about 10% of patients get bilateral internal mammary artery grafting. So what are the barriers to the use of BIMA grafting? And I have put some of them over here. using two mammary arteries makes the operation longer. No matter how experienced a surgeon you are, in your hands, using two mammary arteries will take longer time than using a mammary and a piece of vein. Using two mammary arteries is slightly more technically complex than using a single mammary and a piece of vein. And there are problems with limited availability. When you use two internal mammary arteries, that's the length you have. You can skeletonize it and get an extra inch or 2 inches, but that's the length you have. Whereas in saphenous vein, you can have more vein if required, if you have problems. Now, there are some complications which are unique to using or harvesting the right internal mammary artery. So the incidence of immediate complications is slightly higher when you use bilateral internal mammary arteries. All those who use the right internal mammary artery routinely will remember that at times they must have gone back to theaters and found bleeding from the right internal mammary artery bed. We've heard that sternal dehiscence incidence is slightly higher when you use bilateral internal mammary arteries. And the most important reason is surgeons tend to be in their comfort zones. There is a lot of scrutiny of surgeons, and we are assessed on our immediate results. And therefore, there's a tendency to do an operation that you're comfortable with and that you can perform in a reproducible fashion. And therefore, that is one of the reasons why there is no appetite to do bilateral internal mammary artery grafts. And there's no benefit or incentive to the surgeon, especially when the benefits of bilateral grafting are in the very distant future. And again, the radial artery is available. The radial artery is easy to harvest, is easy to handle, is more forgiving, and more importantly, you can harvest the left radial artery while you're harvesting the left internal mammary artery, so there's no extra time being used. Bilateral internal mammary arteries is not a generic operation, it's not a standard operation, and the level of experience, skill, and concentration required when you do BIMA grafting is more than when you do a single mammary and a vein graft. If you are using T grafts and doing a lot of sequential anastomosis, there is always a chance of technical imperfections, and they will carry a significant penalty in the immediate term. So these are some of the barriers to why BIMA grafting is not commonly used. And I would also say that many believe there is lack of evidence from randomized controlled trials. And I'll come back to this in a few seconds. There are many situations where BIMA grafting is not appropriate. For example, if the life expectancy is less than 10 years, if you have a combination of comorbidities of diabetes, obesity, and COPD, then obviously BIMA grafting is not suitable. There are certain anatomical situations where it's not possible to use BIMA grafting in cardiomegaly patients or when there's distant disease. So coming back to the lack of evidence from randomized trials. Now there are, as I said, there are dozens of observational studies, large studies, which have shown a benefit. And I showed you this slide a few minutes ago. This is from the Kurlansky study of 4,500 patients. They looked at patients who had SEMA grafts versus BIMA and found a survival difference at 25 years. Now, of course, this was an observational study. There were differences in pre-op characteristics, and therefore they had to use statistical methods to adjust for those differences. And they stated that when they stratified for propensity score to undergo BIMA grafting, there was no difference in in-hospital mortality. But if you look at the numbers more carefully, the raw numbers, the in-hospital mortality for patients who had single mammary was 4.5% versus 2.6% for BIMA grafting. So obviously, the population of patients who had single mammary artery was different than the population of patients who had BIMA grafting. And let's look at those differences. The patients who had BIMA bilateral mammary arteries were males, were younger patients, and patients who had single mammary artery had a lot of these risk factors: diabetics, smoking history, renal dysfunction, poor LV, etc. And there are many surgeons who believe, and I have some sympathy for this viewpoint, that there's a problem with conclusions that you can draw from observational studies. Many surgeons believe that the bias in selecting patients for BIMA grafting is so strong that no statistical method can adjust for the pre-op differences. And I'll raise my hand up. In my practice, the patients with the best protoplasm almost always get a BIMA, bilateral mammaries. And the patients with the worst protoplasm almost never get bilateral grafting, bilateral mammary. And in between, there's a gray area. And I tend to use bilateral internal mammary arteries. But I'm sure if somebody looked at my results in the long term, the patients at the far ends will skew the results. The good protoplasms will survive for a longer period. And one other point I would like to make about observational studies, which have a long follow-up, that these were operations done in the 1980s and the 1990s. And since then, medical therapy has evolved. So we have statins and ACE inhibitors, which will improve survival in all patients, whether they have CIMA grafting or BIMA grafting. And therefore, as time progresses, survival benefit of BIMA grafting will be less apparent. So in summary, even though arteries are better conduits, they have better angiographic results, and they have better survival benefits, we have to wait for randomized controlled trial data. And the thing with randomized controlled trials is we have to keep an open mind. We do not know what ART will show. It may show BIMAs are better. It may show results are equivalent. We'll have to wait and see. And for those who would like to increase the proportion of patients in their own practice from, let's say less than 10% to 25 to 30% of BIMA grafting without an increase in morbidity and mortality, and I think no surgeon should operate outwith their comfort zone. I would have a few simple tips to make an absolute midline sternotomy. Set yourself enough time for the operation so that you do not have any commitments later on that day. Skeletonize the arteries either during or after harvesting. I harvest pedicle grafts and then skeletonize the artery after harvesting, and I can easily get an inch or 2 inch longer, and use in situ grafts rather than a T or Y grafts in the beginning, and use end-to-side anastomosis as they are simpler. For sternal closure, use at least 8 to 10 sternal wires, and especially in the lower end of the sternum, use lots of wires. That's the reason where the sternum starts moving initially. I use Colatemp in all my patients, and Colatemp is gentamicin coated fleece, and I don't put it in between the sternal halves. I put it under the sternal halves, and in my personal experience, the sternal dehiscence rate is about 1%, whether it's single mammary arteries or bilateral internal mammary arteries. And there are lots of other slides, but I think we should keep some time for questions.